Alright, here's my environmental check. Your patient.
Just show the dry erase board that it's just a calendar.
Oh, my dry erase board is just my calendar with all of our lovely tests on it. Okay. Okay. Alright. Hi, my name's Allie. I'm a Nova PA student, and I'll be doing your respiratory, cardiovascular, and abdominal exam today. Alright, I'm going to wash my hands with soap and water. I'm stating that the patient appears healthy and in no apparent distress. The patient usually would take her shirt off, but since it's on YouTube, I'm going to have her keep it on today. Alright, I'm going to start off by inspecting the anterior and posterior chest. I'm inspecting for any, for the symmetry of anatomy, the contour, the AP diameter, skin lesions, superficial veins, lesions, and central cyanosis. Alright, I'm going to have you turn a little. Okay, I'm going to put my hands at 210. Okay, I'm going to have you breathe in and then out. Okay, chest expands symmetrically. Alright, I'm going to have you hug yourself. I'm palpating. I'm looking for any deformities, step-offs, crepitus, masses, or tenderness, and none are noted. Okay, now whenever you feel my hands against your back, say 99, okay?
Okay. 99, 99, 99, 99.
Okay, tactile firmness is equal in all fields. Alright, now I'm going to do the diaphragmatic excursion. We usually do this bilaterally, but for this exam, I'm just going to do it on one side. Okay, just breathe normally. Okay, take a big breath in. Okay, now breathe out, marking that position. And measure. Okay, the diaphragmatic excursion is 4 centimeters. Alright, now I'm just going to percuss along the back in the 7 positions in a ladder formation. This is 5, 6, 7. There's no dullness to percussion. Okay, now I'm going to check for CVA tenderness. Any tenderness?
No.
No CVA tenderness noted. Okay, now I'm going to listen in those 7 places, again in the ladder formation. Whenever you feel the stethoscope, just breathe in and out through an open mouth, okay?
Okay.
And I'm going to use the diaphragm side. Okay, there's no adventitious breath sounds noted. Alright, I'm going to turn you. I'm going to check the axillary lymph nodes. Usually this would be done bilaterally, but today I'm just going to do one side. Alright, if you could put your hand up here. Okay, I'm going to start by doing the anterior. I'm just going to grab this skin. Using both of my hands to palpate down. Okay, I'm doing the central, the posterior, and the lateral, and the epitrochlear. Okay, there's no lymphadenopathy noted in the anterior, central, posterior, and lateral nodes. Alright, I'm going to have you lay down at a little bit of an incline, so I'm going to put these pillows here. I put the laptop over here. first I'm gonna palpate the anterior chest wall. Okay, the chest wall is clear of any masses, tenderness, or crepitus. Now I'm going to do tactile firmness in the front with you, okay? But I'm just gonna do it in the 3 areas instead of the 4 like we did last time. Okay, so whenever you feel my hand, say 99, okay?
Okay. 99, 99, 99.
Okay, tactile firmness is equal in all fields. Okay, now I'm gonna percuss. This time I'm just doing 6 regions on the anterior chest. Then I'm gonna percuss. Okay, so just relax. 1, 2. We're skipping 3, 4, 5, 6. Okay, there's no dullness to percussion. Okay, now I'm gonna listen again to the 6 places I just percussed. I'm gonna start with, or I'm gonna listen to 6 places on your chest. I'm gonna start with using the bass to listen to any for the apices. Then I'm gonna switch to the diaphragm. I'm using the bell. Did I say bass? I'm using the bell to listen first at the top part. Okay. Like I said before, when this touches, just breathe in and out normally with an open mouth. Using the bell side first. Okay, now I'm switching to the diaphragm for the rest of them. Okay, no adventitious breath sounds noted. If there were adventitious breath sounds, I would perform one of my 3 special tests, and today I'm going to be performing the egophonia one. So I'm going to have my patient come over and sit in this chair for me. Okay, I'm gonna have you sit like that. Okay, so I'm going to, whenever you feel my stethoscope on your back, I want you to say E, okay? Okay, I'm gonna be using the diaphragm side for this. Okay.
E, 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 E.
Okay, if this test was positive, instead of E, I would be hearing A, but I'm hearing E, so this test is negative for this patient. Alright, that concludes the respiratory exam. So now I'm going to do the cardiac exam. Oh, thanks. Okay, so first I'm going to check for any carotid bruits. So I'm going to have you, are you okay?
Yeah.
I'm going to use the bell side for this. So when I put this on you, I'm gonna have you hold your breath, okay? But you can breathe normally for right now.
Okay.
Okay, I'm gonna fill for the carotid. Okay. Okay, hold your breath. Okay, you can breathe normal. Okay, hold your breath. Okay, you can breathe normal. No carotid bruise heard. Okay. Now while you're here, I'm going to go through the 4 valvular positions and Erb's point. I'm just going to listen with the diaphragm first, then the bell. Not that you know what any of that means, because you're the patient. Just going to listen to your heart. Alright, diaphragm side. Okay, I'm starting at the aortic, the pulmonic, Erb's, tricuspid, and mitral. Okay, now I'm switching to the bell. Mitral, tricuspid, herbs, pulmonic, and aortic. Okay. Alright, now that I have you in this position, I'm gonna place my diaphragm side on the herbs point, which is the third left intercostal space, and I'm going to have you take a big deep breath in, hold it a little, and then exhale, okay? Alright, big deep breath. Okay, exhale, perfect. Alright, the physiologic split of S2 was just heard. Okay, now I'm going to be checking for any aortic regurgitation, murmurs, so I'm going to have you, when I tell you to lean forward, you're going to breathe in, and then you're going to exhale hard, okay?
Mm-hmm.
And I'm going to use the diaphragm side again at herbs point again. Okay, lean forward, breathe in, breathe out, and hold it. Okay, perfect, you can breathe normally. There's no murmurs of aortic regurgitation. I'm going to use the diaphragm side again at herbs point. I'm going to have you, when I stick this on, I'm going to have you bear down like you're taking a bowel movement, like you're passing a bowel movement, and I'm going to listen for any murmurs, okay?
Mm-hmm.
Okay, bear down. Okay, perfect. No murmurs with Valsalva. Okay, now I'm going to have the patient lie down again for me. I'm checking for JVP. I'm going to have the patient turn her head to the left. I'm identifying the SEM. Okay. I'm going to put the ruler on the sternal angle vertically. Like this. Then I'm going to use this flat edge tongue depressor. I'm going to put it at the highest point of oscillation. Ooh. Computer's going to sleep. Okay. I'm going to measure that. Okay. Jugular venous pulsation is about 4 centimeters above the sternal angle. It's visible about 4 centimeters above the sternal angle when the patient is 30 degrees. Okay. Next, I'm going to get my pen light. Sorry, Alfie. And I'm going to just look over the precordial. Okay, I'm inspecting for any precordial heaves and the point of maximal impulse, okay? Now I'm going to palpate the valves, aortic and pulmonic, herbs, tricuspid, mitral, and I'm going to find that point of maximal impulse, the PMI. Okay. There are no lifts, heaves, or thrills, and the PMI is non-displaced. Alright, now I'm going to listen to your heart again, like I did before when you were sitting up. Okay. First I'm going to use the diaphragm side, then the bell like I did before. Okay. Aortic, pulmonic, herbs, tricuspid, and mitral. Okay, now I'm going to use the bell, mitral, tricuspid, herbs, pulmonic, and aortic. Okay, now I'm going to have the patient lay on her left side, Ralph. And I'm going to use the bell side for this, and I'm going to put it under the mitral area and listen for any gallops. Okay, there are no gallops or S3 or S4 heard. The rate and rhythm are regular. There are no murmurs, gallops, or rubs heard. Okay, now what I'm going to do is I'm going to palpate the arteries. So We did the carotid, but I'll do it again. I'm gonna do this unilateral because I don't want to put her to sleep. Okay, everything else is bilateral, so I'm gonna do brachial, radial. Usually we do femoral, and when we do, usually we do femoral right now, but we're not doing that today. Okay. Bend the knees, please. Popliteal. Sorry. Okay, then I'm gonna go in between, behind the medial malleolus. Okay, right here. That's for the posterior tibialis, and then have your flex your toes, relax them. Okay, then dorsalis pedis. Okay. So pulses are full and equal bilaterally. Okay. So after that, I'm gonna check the nail beds. I'm gonna pinch them a little bit. I'm gonna check the toes. Okay. There is no peripheral clubbing or cyanosis, and capillary refill is less than 2 seconds. All right. Now I'm gonna inspect the legs. I'm palpating them. I'm inspecting for any edema, the hair distribution, skin condition, varicosities, and I'm checking with the backs of my hands for the temperature. Okay, perfect. All right, that concludes the cardiovascular. Now we move on to the abdominal, which I'll just put it like right here. Okay, I'm gonna remove these pillows from the patient. I'm gonna ask the patient to lay in a supine position, so completely flat. If you could bend your knees, keep your knees bent the whole exam, okay? And your hands by your side, supine position. Keep this position the entire time. Oh, he's checking on his mom. Okay, perfect. I'm gonna expose the abdomen for this exam. Okay, first I'm examining the abdomen. The abdomen is flat and non-distended. So, okay, first I'm gonna listen, which is a little different than the other ones. Okay, I'm using the diaphragm first to listen. I'm listening in the right upper quadrant, the left upper quadrant, the left lower quadrant, the right lower quadrant, the epigastric, the umbilical, and the hypogastric. Vowel sounds are present. Okay, now I'm going to switch to the bell, and I'm going to be listening for any bruits. Okay, I'm going to start with the abdominal aorta, then the left renal, then the right renal. Yeah, I think you're hungry. And then the left iliac, the right iliac.
Try not to sneeze.
What?
You've been trying not to sneeze.
Oh, sorry. You could sneeze. Okay, so normally we do the femoral arteries, and we'd also examine the inguinal nodes at the same time, but today we're not doing that. So there are no bruits noted, and the femoral pulse is full and even bilaterally, and or equal by the femoral pulse is full and equal bilaterally, and there's no inguinal adenopathy. You can sneeze if you need to.
It's okay.
All right, now that we did that, we listened. I'm gonna start percussing. Okay, so I'm gonna percuss over those areas again, okay? I'm percussing for any tympany or dullness. Okay, as I said before, percussing for any tympany or dullness. Okay, now I'm going to percuss the liver. Here, I got it. keeps falling asleep. Alright, so, okay, I'm going to start down here. I'm going to start in the mid-clavicular line, and I'm going to start by the umbilicus. Okay, right here, I'm going to mark that. I'm going to start up here, work my way down. Sorry. Okay, now I'm going to measure those two areas I marked. Liver span is 6 centimeters at the mid-clavicular line. Okay, now I'm going to percuss the spleen. Take a big deep breath in. Okay, you can breathe normally. Okay, there's no splenomegalia with tympany, noted with tympany. Okay, after I percuss, I'm going to do a light palpation in those quadrants that I did before, okay? Okay. Right upper, left lower, right lower, epigastric, umbilical, hypogastric. Okay. There's no tenderness, guarding, rigidity, or masses with light palpation. Now I'm going to do deep palpation in the same areas I just did, okay?
Okay.
Right upper, left lower, right lower, epigastric, umbilical, and hypogastric. Okay, there's no, my patient is asleep. There's no tenderness, guarding, rigidity, or masses noted with deep palpation. Okay, now I'm gonna do the rebound tenderness. I'm gonna put pressure in the right lower quadrant. So I'm gonna apply pressure to your right side. If you feel anything when I'm applying pressure, or especially when I'm withdrawing my hand, let me know, okay? So I'm gonna apply pressure in the right lower quadrant. Any pain at all, especially when I withdraw my hands?
Nope.
Okay, there's no rebound tenderness. Alright, now I'm going to do the abdominal aortic, palpate that. I'm going to take my left side of my hand with this. I'm just going to... Okay. Abdominal aortic is 2 centimeters wide, and there's no lateral expansion pulsations. Okay, now I'm gonna go ahead and palpate the liver. Right here. Okay, give me a big deep breath in and out. Okay, the liver is non-palpable and non-tender. Now I'm gonna have the patient turn on the right side. You could just maybe flip. And I'm going to palpate the spleen. Okay, the spleen is non-tender and non-palpable. Okay, you can just flip to your things. You can just flip over, lay on your back again, expose the abdomen. Here I'm going to be checking for any abdominal reflexes. I'm just going to, this might be a little cold, but I'm just going to stroke this like diagonally from your belly button. Okay, no abdominal reflex is present. Okay, now usually I would do the genital hernia and rectal exam, but luckily for my patient today we're not doing that. And okay, so now my last step, out of the 6 special tests, I'm going to be performing the heel tap and the Robsing's test. So for the heel tap, I'm going to have the patient put your legs down, extend one leg, hyperextended, don't bend this knee, okay? I'm just gonna tap. Any pain?
No.
Okay, if the patient felt pain anywhere, especially on the right upper quadrant, that's an indication for peritonitis due to appendicitis. Okay. Then the Rovsings. I'm gonna put pressure on your left lower quadrant, and if you feel it on your right side, let me know. Okay. Okay. I'm just gonna apply pressure and withdraw. Any pain on that right side?
No.
Okay, if the patient had pain or felt pain, it would be the rebound, and that would be indicative of appendicitis. All right, the end.